Okay, very good. The webinar is being recorded. Oh, it was being recorded before. All right. So let's see. So this is week 8, and this is technically the last week of the Thoughtful Thursdays. And I want all of you to know that I appreciate your feedback, your private texts, private emails, because you keep me going. I found that there's something about this that is bigger than us. And what I mean by that is one of the questions, yes, we're talking about behavioral health training today. And this was the 8-week course, etc. Now, this is the wrong PowerPoint. 1 second. So give me a second. I'm stopping the share. I'm stopping the record because I have them on. Give me 1 second. Here we go. I'm sharing the screen. God willing, it's the same one. I mean, the correct one, because there are multiple ones. Yes, this is it. Okay, very good. Okay, so here we go. This is week 8 of the requirements of participation, education, and training sessions that are available for you to use and for your staff, because the government has stated that by October 24th, 2022, all of these areas require training for all staff. So let me just jump to that so you can see that. These are the 8 areas. They're all on YouTube except for this week's, which is behavioral health. And these initial our educational series are great, and in my opinion, that they give you an overview, but there are much more details that you need to look into. And what I mean by that is that you'll see a common thread throughout the ROP that mentions, what does your facility assessment say? Have you referenced your facility assessment? So we'll get into that this session as well. So this is the last week. My question that I was going to, but I didn't have time because I got an emergency phone call, was, what do you want me to do next? Because you've been a consistent viewers, and I would say that those that have attended the majority of the weeks. And the ROP, so this is number 1, in my opinion, ROP, and I'll show you why. Number 2 is beneficiary notices, and 3 is dementia training, which I do think is super important. And they're all important. They're equally important. So, but let me know. You can chat me, etc. You can, whatever. Now, what do I mean by ROP 62922? What I mean is that we have reviewed in the last 8 weeks what you have been required by the government by October 24th to train your staff. There is a whole litany of other expectations in this requirement, and we haven't even touched those. So, and what do I mean by beneficiary notices? I mean NOMNACs, ABNs, advanced beneficiary notices. This came up because of a specific client in Connecticut. And and by the way, the ROP specifically says they're going to do a sampling of your beneficiary notices. And there are lots and lots of opportunities in these. That's another discussion for another day. And then dementia training, which falls under the umbrella of behavioral, but there are multiple things under it, and giving you resources to know who to call, how to train, etc. But with regards, these are all of the sections of the ROP that we have not addressed yet. I have addressed it internally in the Harmony organization and with our monthly clients, but binding agreements, your ability to admit or transfer patients, behavioral health services, it gets a deeper dive, compliance and ethics. We've talked about how to train, but what are the expectations? Food and nutrition, freedom of abuse and neglect, infection control, pharmacy, physical environment, physician services, psychosocial outcome severity grid. And that will be addressed today. That is in part of this training that the government has guided you to shift to use this particular document over Appendix PP. QAPI, quality of life, resident rights. Do I have that twice? And staffing. training requirements, and then handouts and downloads. But this particular has not been public yet. I only did this internally. I'm thinking that this is what we should do next. Your call. You let me know. And so we begin our agenda for today. And the goal of today, now remember, for those that need CEUs, for those that need CEUs, you have to take a quiz, and the quiz will be 5 to 10 questions. And the goal is that, yes, you were here and yes, you showed up, which, as Woody Allen says, 70% of life is showing up, but you also learn something. And I try to simplify it, and I try to de-stress things. So the goal is for you to, there's a new definition for substance abuse disorder, and it was added into that ROP. I want you to understand what the purpose of the psychosocial outcome severity guide is. That is a couple, I've baked it into the PowerPoint, but it is also a separate handout that CMS has created for you. And I also want you to understand what falls under behavioral health. And, dementia, SUD, anxiety, bipolar disorder, post-traumatic stress disorder, to name a few. In other words, I am thrilled that the government has identified, and, I feel as though mental health was a scarlet letter in healthcare. And I've said this to you numerous times, your mental and emotional well-being affects your physical health. In fact, studies have shown that it is actually more potent / impactful to an individual's health than physical. Let me say this a different way. So we'll get into it too as well. Physical harm or physical abuse, let's just say, versus emotional abuse. The ramifications of emotional abuse have far greater negative impacts on an individual than physical. Sounds a little bit weird, but it's what the studies are showing. Let's just make sure I did. Okay. I would like to continue on with the training past this week. Okay, very good. Thank you, Deborah. I appreciate it. I feel as though this is what I'm sort of feeling these sessions are. It's like this 1 hour a week, we get together and we're going to talk about, because it is impossible for you to read everything, and you get nugget of information, a takeaway, and it's just going to add value to your skill set as a healthcare professional. So thank you for that. And so, but the overarching theme is that, I am an occupational therapist, as you know, and before I could become an OT, I had to work and do what we called, not internships, but clinical rotations. And we had to do them in different settings. One would be physical dysfunction. So I worked at the rehab hospital. And then the other one was psychosocial, mental health. And I worked in a day treatment center for adults that had a multitude of DSM-5s. And for me, one of the things you'll hear me say is that all of us, everyone has their own demons, journey, etc. The ability for someone not to technically have a diagnosis is their ability to cope, their coping mechanisms. And if someone has a coping mechanism, it will allow them to live a healthier life. That coping mechanism could be running, it could be Netflix, that's mine. It could be walking every night. It could be yoga. It could be a glass of red wine. It could be going to a movie with your friends. Whatever it is, it's what keeps you balanced. And we don't judge as healthcare professionals what other people do. In other words, we know that the ramifications are this DSM-5. 5 out of 10 United States individuals will have a DSM-5 in their lifetime. So that's, and by the way, I give you that statistic because that means 5 out of 10, 50%. And that's what about the ones that really have a DSM-5, but they did not have it professionally diagnosed. So the overarching theme of today is that substance abuse disorder, which, and the knowing what the psychosocial outcomes severity grid is, and for you to understand what falls under the umbrella. And that's the goal. I call it chunking, right? We're going to chunk. We're going to learn a little bit at a time. Now, what I did with this webinar is a little bit different than what I do with the last ones. I felt as though I needed to go back to the bigger PowerPoint to tell you what the changes are. And so as you can see that, and I like to associate them with the tags. So under the behavioral health services tag 740, that they removed CMS, they as CMS, removed their reference to Appendix P and added this reference, which I have for you. And but in the tag subject line, it says behavioral health services. And then red number 741 is competent. Oh, so in other words, how do you become competent, right? So you, other than the mere fact is, number one is, okay, step number one is to know that, oh, if we have these type of residents in our facility as defined by our facility assessment, then we have to be sure that we have a program in place in order to ensure that our direct care providers are competent and they understand the nuances of treating them, these individuals. The language for the behavioral health tag added language that talks about a history of trauma and post-traumatic stress disorder. And again, I will say this because I commend the veterans, and as an occupational therapist, my profession was created out of the veterans. Occupational therapy, come back from war, they needed to reintegrate into life. It's not that an OT gets people jobs. We function everyday life, activities of daily living, bathing, dressing, grooming, going to work, right? So but you know, the term trauma, the term post-traumatic stress disorder is much more understandable in the context of the veterans because it's very obvious to individuals why they would have that. The ROP transcends into the fact that a non-veteran could have PTSD due to a litany of reasons. And for you, the healthcare provider, to be able to identify said diagnoses, or again, they may or may not have the diagnoses because, let me put it this way, if they have the diagnoses, great, they're going to hand it to you. But I am also going to say, as a 32 years in this industry, that there are going to be multiple individuals that will be under your care that do not have a diagnosis, and you should be aware of it. And substance use disorders, that is the acronym SUD. And just to connect the dots, that if someone has a DSM-5, they would be more likely to abuse substance abuse. And the reason why is that a pain killer, a pain med that my leg was, I have a broken leg, and I'm going to get a pain med to fix my pain, well, so I won't feel it, but a pain med also decreases emotional pain. So if you know anyone, and by the way, the United States has been in this crisis for 20 years now. And again, it's just an unintended consequence, I suppose. Pain used to be the sixth sense, and, address it. And then unbeknownst, maybe beknownst, I don't know, that there's this massive addiction factor, and you have a pain med addiction. So you have to be aware of that. There are individuals that, are kind of come into your buildings and be admitted, and there probably could be of that era that was the unfortunate population that got caught up in that. And never, ever, ever judge someone that you perceive or is diagnosed with substance use disorder. It is at the molecular level. There's nothing they can do. In other words, they're about, I think it's called, there's 20%, 2 out of 10 individuals have what they call the lucky gene, and the lucky gene the person has an advantage. They do not have an addictive propensity. So some people will have pain meds for some surgery and they'll never get off of them. So it is what it is. It's the way it is. So right here on this column here, tags 740, 741, 742, treatment, services for this, referencing this guide, 743, behavioral difficulties unless unavoidable. So in other words, I'm giving you the tags and the associated regulation interpretive guidelines. And that's where we're at. Okay. All of the tags under the behavioral health services section were revised except for 745. And so the changes to the tags 742, 743, 744 were technically minor, but the removal of the reference to Appendix P and the addition of the psychosocial outcome severity grid. They also, and this is very common, always referencing that PASAR. And again, it's the pre-admission screening for a resident coming in. And the reason you do this is to ensure that a resident is being admitted into the right environment. Likewise, that the environment has the staff, the competencies, and the ability to care for that resident. The language also goes into behavioral contracts and some specific issues there. But again, behavioral contracts, you must be sure that you are not overstepping your bounds with regards to resident rights. And the other areas in this final rule, ROP requirements, ROP, the information has been added for schizophrenia and bipolar disorder, and there's a new severity level 4 under the deficiency categorization section. And there are resources as well. We can go there, but at the end of the day, I know that what I will say to you is that you have your organization and your facility assessment, and the specifics of your facility organization have to be threaded and baked into your program. So let me say this a different way. If you have a component of behavioral health diagnoses in your facility, which would be defined in your facility assessment, you want to discuss types of trainings that you have, or you want to be aware that whatever your mix is, whatever word you want to call it, the government expects that your training competencies are aligned with that. And I'm going to say this again, because if you think it's easy to determine your demographics of your clients, it's not, because you could have, I've looked at charts that have had 40 diagnoses, 40, one patient, 40. So, and I've also noticed that in the last year, they've been bejangled, like the ordering of diagnoses, et cetera. So if you're going to extract data from your wonderful electronic health record system, there's a thing called GIGO, garbage in, garbage out. If it's not entered properly, you're going to get misinformation coming out. So define who you are, right? You need to be able to define who you are. So let's keep going. At 740, behavioral health PASAR, we talked about. And again, what I just said earlier, that if you have a behavioral contract with a resident, it cannot conflict with resident rights or other aspects of the ROP. To remind you, the requirements of participation are created by the government, because you as an entity receive revenues, reimbursement from Medicare or Medicaid. You receive governmental funding. Therefore, you are obligated to follow their rules of engagement. So we mentioned this as reiteration: schizophrenia and bipolar disorder, the depression and anxiety disorders. There are multiple DSM-5 categories. And there's been an influx in DSM-5 categories. There has been an influx as a product of technology and as a product of the pandemic. So that you were aware that, so for example, we talk about loneliness, and loneliness is different than depression. So by virtue of everyone being isolated, quarantined during the pandemic, it has impacted people's mental health. So, and I'm not quoting any specific research, but I'm saying that there's been a definitive spike, increase in these DSM-5s, whether it is a product of it, or is it people become more self-aware. I'm sure the studies will come out showing that as well. So that's a reiteration. In the italicized light purple is what is in red. I just couldn't do the red because it stresses me out. In red in the requirements. And what the ask is from the government is that ensuring that your staff have the sufficient skills. A second, I just have to move you because I have to know what slide I'm on and I can't see what slide I'm on. Second, here we go. 21, okay, 20. I take notes myself, I make edits. The trauma, they added this trauma. What is trauma? It results from an event, a series of events, or a set of circumstances. And the individual, okay, they experience it either physically or emotionally harmful or life-threatening, and it has a lasting effect, a negative, an adverse effect on their functioning, their mental, their physical, their social, their emotional, and their spiritual well-being. So, as you are probably aware, that individuals can be traumatized by their childhood and their adulthood. Any interactions that happen can affect someone's ability to function. What is the ability for the person? How do they coping mechanisms? Okay, so it's all about these coping mechanisms, how they're going to cognitive behavioral therapy navigate through them. And behavioral health, as yay CMS, yay SAMHSA, that they are bringing this to the forefront. It has, for those of you that are not old enough, this would be a stigma. And in fact, under the Medicare Part A and Part B, there was probably a decade or so that individuals thought that they could not treat a patient, meaning therapy-wise, if they had any of these stigmatizations. And it's simply not true. I have known my whole career it's not true. That's how we were trained, but that doesn't mean that the world knows it that way. So an individual has something occur. Now, I will tell you the story about, there's an example that I want to give you. And the example is that in about a decade ago, I was in New York City. And I remember I'm a very efficient individual. I do multiple meetings. I am just insanely organized. And I have organized people around me. So I'm in New York. And one of the reasons why I like to go to New York is one of my best friends who went to college with me. She has a rare disease. It's called MELAS, MELAS, mitochondrial encephalitis. Basically, it affects her. She's had a heart transplant, she's had a kidney transplant, she's hard of hearing, etc. But I like to see her. So, but I'm in New York and I go to a meeting, that bull, like on Wall Street, come down the elevator, and my ex-husband at the time hands me what I call Christmas in the cup. It is a latte. And I'm like, ooh, from Starbucks. And like, this is awesome. And he looks at me and goes, listen, we should zip over to Ground Zero. And I'm like, I don't have time, but all right, fine, let's do it. And I acquiesce and I go, and then I have to go through security, and they take my Christmas in a cup, which is frothy and just wonderful with cinnamon on top. And I'm like, okay, so I go into this area and I walk in, and my high school prom date, senior year, was in the building. Now, I go into the Ground Zero and I walk into a room, and I'm going to say the room was 12 by 12. Couldn't have been any bigger. And there's a table, like what do you call them in your kitchen, an island. And in the island, you find the person that you know, you push the button, and then on the wall projects their face, and then the voice of one of their loved ones will describe that person. So they go on to talk about him and his pictures up there. And I'm not a big crier, just so you know, I'm a quadruple Capricorn, probably have a tinge of Sagittarian in there. But the point is that I'm not emotional per se. So, but now I watch it, and then we go and we sit into this other like little mini stadium, and they recorded the evolution of the development of the area, and they fast forwarded it. So now at that point, I look at my ex-husband, I say, I don't feel well. I think I touched him dirty, and I think I have the flu, and I got to go back, and we have to go meet people. You know what? So we leave. Okay, fine. So now I go back to my hotel room, and then I go to dinner with an administrator from New Jersey, an employee, and my best friend from college. And so I start to say to her, I say, Samantha, I said, I went to Ground Zero today, and they have it all wrong. I said, they have this like cathartic type of thing, like it's therapeutic. And, my 4 daughters, they need to know exactly what happened. I mean, Carissa was 9 months, if that, when it happened. She was born in 2000, something in 2001. I'm like, Samantha, what she does, she's across the table from me. She doesn't give me eye contact. And she says, yep, we won't go there. We'll never go there. We saw people jumping out of windows, businesses closing. Okay, she had no emotion. She could not talk about 9/11 because where does she live? In Manhattan. She lived it. Here I am now, how long, maybe a decade later, 15 years, maybe 14 years later. I'm going to say it was a decade to 14 years later. I'm looking at her thinking, whoa, she is totally impacted by this, and everyone that lives in New York. I give you that example because you don't know when someone's being admitted what their journey has been and what is going to impact them. And as you can see, as you go on, the symptoms, right? Because what do we do when we have trauma? We repress it. We're going to put it away. We're going to compartmentalize, right? And we're going to put it away. So it occurs when someone has encountered a shocking, a scary, or a dangerous situation. And the symptoms could begin early, within 3 months of the event, or they might begin years later, okay? Part of this also is that, there are rules with DSM-5, there are rules, and whether those rules are a perfect science or not, I don't know. But I can say that all of us have instances of things that have occurred to us that may be drawn out. It could be a smell, it could be a sound, it could be a song, it could be a person, it could be a name, it could be something. And I've mentioned this to you earlier, that when you have residents, it is the burden, the responsibility is on the facility to know that, okay, we have to do a comprehensive job of assessing if this individual has any concerns, that because we want to make sure that they're at their optimal level of physical, mental, and psychosocial well-being. So, and what could trigger it? And again, to reiterate it, the mere fact that a senior is admitted into an assisted living, an independent living, a skilled nursing facility is a trigger. You are changing their environment. You are putting them in a new environment. So I just want you to think about trauma, think about emotional reactions, and think about how your organization addresses them and talks about them and identifies them. So again, we're in the opening remarks here, and the history of trauma, because if you have a history of it, do you have, once you have Lyme disease, do you always have it? You sure do, because it's in your body, right? Once you have the chicken pox, you have the virus in you. So the key element is that looking for that higher risk classification, hear me out, but not being myopic to the fact that it doesn't have to be the obvious veteran. It doesn't have to be the obvious person that lived through a fire, a shooting, a trauma, an earthquake, a tsunami, all of those things. I would have absolutely missed 9/11 as a trigger. I would have missed it until I saw her response. No reaction. So okay, very good. So events or series, I like to put this in different slides so you can assimilate it and put it into your brain. It could be an event, a series of events, or a set of circumstances. Now, there are individuals that have been physically abused. There are individuals that have been emotionally abused. And what a sidebar, not so sidebar conversation is that there is a lag between the law and the reality. There are some states like Connecticut, California, Hawaii, New York, and Texas that their legal system is very apprised of emotional abuse, but the legal system would only consider it if someone, they punched you in the face. So, they pushed you, they shoved you, they hit you. There is a huge attention on this area. And I tell you this because you're healthcare providers, and that, IPV is called intimate personal violence or coercive control. There are individuals out there that will never punch or hit an individual, but they will threaten them or control them or, legally abuse them. And those things have long-lasting effects on individuals and patients and people that are coming in. You are ahead of the curve, but why it's important for you to know is that these assessments are super important in order to do a proper care plan for an individual. So, and again, we navigate through it as we go. And everyone has a different coping mechanism. And the other part is, just because someone is not reacting, someone's reaction to a situation is not what you don't assume that your reaction is the right reaction. Maybe you would cry, or maybe you would hide, or become introverted. Some people may do different things. Be very open-minded about someone's behaviors in relation to the instance. And I think that's the overarching theme here, is that behaviors are a clue to what is going on with an individual. So a basic example would be that someone is refusing care. They're punching, they're hitting, they're aggravating, right? And of course, again, a sad example, but then, okay, give them a tranquilizer, calm them down. Well, they're frustrated because they can't communicate. Maybe they have expressive aphasia and no one's listening to this person. So don't assume that aggressive or hostile behaviors are a scarlet letter in the context that they're not going to change. They could just be someone that is completely stable, that has had enough of some situation. And I did give you an example of one of my in-law aunts that was misdiagnosed, in my opinion. So, sorry, we go through that. Now you jump to this SUD. It's newly defined. This is one of your objectives. It's a recurrent use of alcohol and drugs that causes clinically and functionally significant impairment. In other words, so what's the difference between, a relative that drinks 7 days a week, okay, they don't have a job and they're homeless, versus someone who drinks every day, but is wildly successful in their profession? Happens, I'm sure. And that the disorder occurs when they're not functional. Now, how do I say this? I still say that an individual that has, we do not judge, that if someone has some mechanism of having a recurrent use of drugs or alcohol, there could be another area that hasn't been identified. Your job is to try to deep root cause, analyze what is the cause of this. Could it be a molecular level addiction? Could it be some historical event that traumatizes this individual and they never have sought any, attention for it? So, okay, another key element is that the overarching themes, competent staff, new diagnoses with new definitions, your facility assessment is demonstrating the mix of patients. We have 32% of our residents have a DSM-5, Diagnostic Statistical Manual, right? And why is that important for you to know? Well, because an individual with a DSM-5 has a known likelihood of less quality interpersonal relationships. So let's just take autism for an example. And autism, which has been combined somewhat on the spectrum with ADHD, is that remember this now, conflict per Oprah Winfrey, right? This is the Dr. Oprah. Conflict is always a product of miscommunication. Take that basic concept. And if someone misperceives a conversation and they get upset, then it causes conflict. So the statistics show that those with the DSM-5 have harder times with building personal relationships. The less personal relationships you have, the decrease the support system, and therefore to navigate you through your medical health crisis or medical health journey. And I bring that, and by the way, I don't know if you've noticed this, but I also like, when I talk about the seniors and I talk about nursing homes, I like to bring it to us because guess what? We're all getting old, by the way, or as much as we try with the Botox and the injections. But the point is we're all getting older. So this affects us. And the essence of this behavioral is that instead of giving an individual a tranquilizer because they're frustrated, instead of just jumping to the notion that it's got to be them, right? Maybe it's, okay, what could I do instead of giving them, what could I do other than a med? Could it be a room that is softly lit, less noise? And maybe it's an approach that would be less aggressive or offensive or scary. And these are all the areas that you as an operator and direct care staff or management staff have to be looking into. And so, great, we've done that one. Great. Same thing, I put it different ways. I just want it to get in your brain. So your goal, so slide 31 is to write that down. It might change though, but that you have the capacity, the ability to provide the services, and you have the staff with the skills. Now, don't freak out, okay? Because I have worked with many certified nurse assistant, direct care provider that through their own experience have identified it. And yes, you do need to have a plan and an approach on what to occur, but a lot of the techniques with dementia and all these patients and head trauma, they do overlap. In other words, it's not tapping on someone from behind. It's not screaming or yelling. It is movement, body movements, eye contact, level of, standing above someone or standing below or eye level. Maybe a lot of things that therapists or nurses and physicians are taught in academically, but these are the elements for, hey, do the staff, are they aware? And again, I'm finding this Thoughtful Thursday to be something that I'm enjoying in the context of, yes, there's a lot of information, but you're forcing me to package it and refine it and to talk about it with you every week. And it's this journey. So that's a big deal, that you have to take a good look at how your building is addressing substance use disorders and non-pharmacological interventions, and do you have a plan for that? So I'm going to jump over some of these. Okay, so what I did here was, I will show you at the end, remind me if I forget, the actual psychosocial outcome severity guide. It's, like I said, it's 3 pages. I put in here the PowerPoint. Again, I'm an efficient person. Yes, my PowerPoints can have attachments, but I just need one place to look. And I'm not going to go through these, but these are terms that are in this guide. It talks about what is anger, right? And their frustration, and it could be physical. It could be, someone's angry. Okay. One other thing too, and I've learned, or I've surmised, whether it's through reading, whether it's through my 4 brilliant daughters, people that I taught for, and the brilliant people I talk to all over the country, is that when someone is mean to you or angry to you, I'm talking in the context of the nursing home or even in your personal life, they're angry with themselves. They're not, again, maybe you subconsciously know that when you say this out loud, are they really angry with me? Maybe we've all known it, but we just never really brought it to the forefront of our brain. They're angry at themselves for something. We don't know what it is, but so the point is that if someone is angry as a patient or around you, there's a reason for it. So why? Is it because they can't walk? Is it because they can't talk? Could be, who knows? We don't know. We can't judge. This goes right into that person-centered. It's not a care path. It's not a checklist. It is, you have to do your clinical assessment. You have to use your brain and decision tree making on each individual in an individual basis. There's no cookbook for it. And apathy, okay, just to, if someone has little apathy, they're indifferent. You're not really, it's a point in which someone just at that point is the low of the low. They do not care. Okay. They have an indifference. And so this is another great quote, that if someone in your personal life is very angry with you, you know that they still care. When someone gets to indifference, then they're done. How's that one? Just to go there. Anxiety. And so anxiety, another quote that I'll give you, and I got this on TikTok, no lie, that if you are angry, you're living in the past. If you are anxious, you are living in the future, because you're worried about what's about to come. So if you have individuals that are anxious, then you want to quantify, okay, they're anxious, they're worried about something, not something right this second, they're thinking about it. So you have to say, okay, what is their anxiety caused by? Now, it is a big DSM-5, and a big DSM-5 that has shot up with technology and the pandemic, but even pre-pandemic. The example would be that with the 4 beautiful daughters and the wonderful help of my mother and a nanny, you'd come home and my mother, God rest her, she's amazing, she would have the news on. And if they're young and they're listening to the news and they're talking about something traumatic, like, I don't know, decapitating individuals because of, terrorists, and the 8-year-old hears that, one of the techniques to decrease anxiety is to do not have the TV on. The same goes to a nursing home. If you have the news on and the news is talking about horrific things, then that will exacerbate an individual who has a proclivity, a predisposition for anxiety. So long gone are the days in which you're sitting in your dining room and you have the TV blaring. So not to mention, it's just it's a sensory overload. Something to be aware of as well. the reactions, the symptoms could be distributed by restlessness, irritability, hypervigilance, just tense, teeth grinding. And because they're in fight or flight, they're waiting for the danger to occur. And someone with anxiety, this is what one of my daughters had a bona fide diagnosis for, DSM-5. And the doctor said to me, if you tell someone with anxiety that watch out for that door jam, that door, you could trip over it. Someone with anxiety will therefore not leave the house. That is that connect the dots. So either way, I'm just giving you that. Dehumanization is when an individual is treated as an inanimate object, and it's deprivation of all human qualities and attributes and individuality. It is the absolute opposite of person-centered care. It's just disrespect for the other individual. And one of the things you'll always hear me say is in the book, the new gold standard, the Ritz-Carlton, is stay curious, be curious. What do I mean by that? Curious? I don't know who you are. You don't know who I am. I don't judge you by how you look, but tell me about you, because you can learn from the people. So someone could be in a depressed mood, but it's not necessarily, considered clinical depression. And on the MDS, there's a section that you ask the questions. It's the PHQ-9, and that PHQ-9 has sections which help you vet out if someone has, and there's different types of depressive episodes. It could be clinical, it could be, so my Grammy Zasha was in a nursing home, and I would visit it, and she was in a 3-bedroom, and I would show up at 6 a.m. and then the nurse would say, Chris, your Grammy Zasha has depression. Then I call my mother, my Bob, Grammy's got depression. She's like, we don't have depression in our family. We're Polish, we're Russian. I'm like, okay, well, what the nurse said, that's a situational depression. So a fear, this is, by the way, I'm giving you what is in the psychosocial outcome severity guide. Fear, right? Again, this is the behaviors that a surveyor is going to look at when they see a resident. They're going to use this as a gauge on the care. So fear is, a big emotion, a significant emotion that's caused by, you think that something bad's going to happen. Humiliation is when someone's embarrassed. And I do think psychosocial is a very important concept. I use it all the time. Oprah 87 uses it. The psychosocial impact, right? It means my relationships with you, my environment, my physical, my mental, and all of that. And the reasonable person concept is a tool to help the team identify what level of harm, what level of impact did whatever happened that was tagged have on that individual. So you need to know that term, the reasonable person concept. And it's the outcome, the deficiency that would have on the reasonable person in that position. Just write this down. So 38. I hope you guys are doing okay. This is okay. Then in here, you'll have slides on what the purpose of it is, and it's for the surveyors, but you need to be privy to it. So I'm going to skip over a couple of these things because we don't have enough time, which seems to be my theme here. So, but you are aware that this severity guide, okay, is created for the surveyors to gauge, rank, grade, okay, determine what your non-compliance is at the regulatory level. And they have this severity level 4 would be an immediate jeopardy. And an immediate jeopardy, IJ, and it is, okay, so I'm going to give you a couple of points on IJs. So the facility has non-compliance, okay? And the biggest risk about it is that it is likely to cause, okay, serious injury to another resident, okay? Now, we can get into the discussion of whether it's systemic or not. An IJ doesn't have to be a systemic issue. So this particular example of suicidal ideation thoughts, someone is trying to jump from a high place, throwing oneself down a flight of stairs, refusing to eat or drink, hoarding medications with the intent, okay? If someone is engaging in self-injurious behaviors, they're causing harm, they're attempting to cut themselves, they're distressed, they're aggressive, they're hitting, they're shoving, crying, moaning, combative behavior that is not typical for the resident's baseline. And the verbalization, whether it is, well, the expressions, whether they're verbal or not verbal, they have pain that is severe, is more than just transient. Transient means that it's fleeting, it comes and goes. Pain is considered avoidable, and the building was they failed to identify it, assess it, and implement processes to prevent this from occurring from the resident. And a fear that could be manifested out of, immobilization, tying up, any of those areas, someone that has panic and not addressing, they're not sleeping at night, they have fear to even speak. If someone articulates that they're hopeless, they're not worth anything. If they have dehumanization expressions, and if they withdraw. So from not just with their historical. So these are the immediate IJ level, severity level 4 guide for the surveyors. And so number 4, actual harm. Number 3, actual harm that is not immediate jeopardy. Sorry if I skipped over that page, I'm sorry. They've had a decreasing in the above areas identified, and they've had, some psychomotor aspects as well. And they have moderate pain or physical distress, itching, thirst, and has compromised their level. And they are distressed. So, and then we go to level 2, which is no actual harm, but there is a potential, and you can read this later, and for more, and no actual harm, but there is a potential for minimal harm that is not IJ. And then number 1 is no harm with the potential for minimal harm. I think that those are the things I want you to recall. And the areas in which the team will look at the psychosocial, it would be under 48310, 48312. Those are the sections in 21, 24, quality of life, quality of care. Okay, so that's like your overview. Now, what is it that you're going to hyper-focus on training? And we have, of course, not enough time, and we just have to have this journey, making sure that the slides will be ready I usually say within a week. It takes me, I do take a couple of days to refresh these and add, because then what I do is I write the quiz and then I upload it to the system for those that need CEUs. So give me until next week. So person-centered care. You've been hearing about this since 2016. This is not about what your rules of engagement are for an orthopedic, a total knee. This is the rules of engagement for that individual. No two individuals are the same. And it's important that the team, the interdisciplinary team, activate this together and they identify all aspects of this person's cares. And the communication, in other words, they're observing the interactions between staff and residents. They're looking at ensuring that your approach, your understanding, your body language, everything that you do, from eye contact to smiling to being in the moment to not standing above someone in a certain way, body language, they're looking to see that you're doing meaningful activities for an individual. And that goes back to person-centered care. Did they play chess before? Did they like puzzles? Did they knit? Did they paint? What do you have specifically in the care plan for this individual? And what is the atmosphere, right? Is there TV blaring, or do you have classical music playing? Or do you have something in reference that, or do you have no music playing because they're hard of hearing and the background noise would actually impact their ability? Are you applying non-pharmacological approaches? In other words, are you applying, if it's pain, for hot packs or cold packs or massage? And again, the specifics of that patient. It's very easy for automated documentation to be portrayed as cookie cutter. Cookie cutter meaning the same thing. You have to make an intentional effort that your electronic health record allows you to have narratives that are not a pull down and not a deviation from that, so you can put those specifics in there. Yes, there is a great efficiency associated with automation, but it also can put you at risk as well. So the formerly FTAG 279, and now it's F56, and it's the comprehensive care plan, develop, implement. So you might develop it, but you could get tagged if you didn't actually implement. So, and that, by the way, they added the word implement because we wrote, so you could say, oh, I wrote this care plan. Yeah, but you didn't do it. You knew to do it, but you didn't do it. You didn't follow it. So the also under the tag F56, it's expanded, and the patient is the locus of control. The patient is the center of it. And this is good for everyone, right? Because it's not about that assembly line of fractured hip, fractured hip. No. Fractured hip, male, fractured hip, female, fractured hip, 65, fractured hip, 95. Not that age should impact, but more other comorbidities. It is all about the resident's voice. It's all about whether they are articulate or not, that they have a voice at the table and they have control. When you have control over your environment, you are less likely to be anxious. So it's loss of control. So okay, don't have to say that any further than that. Specifics. And, 30 years ago, when I worked at the rehab hospital, we would write on our evaluations, patient's goal. We would say exactly what the patient's goal were for. And that's where this is going. I'm checking the time here. So we are running out of time. I do think in this particular section here, there is something I do want to mention to you. I brought this in as it's under dementia, and I did a presentation in a different state, whatever. And the point is that I wanted to just bring this to the fore table. This will, I will edit this, that with working with dementia patients, you develop an individual goal. There are these 8 essential elements. You perform ongoing review, you develop a team, you assign a leader. That leader can change. You dynamic, ongoing coordination, constantly have transparency and sharing information, provide education and training for all healthcare providers, and identify measurable outcomes. One of the reasons I wanted to bring this in is because this specifics on dementia training, I thought it would be beneficial for the direct front line, and I will add some of this into or keep it into the entire program. So the part that this goes into is I did a session for integrated health services, and it talked, the final comment that I have to say to you on this is that this whole integrated health, I'm not going to say phenomenon because it's not a phenomenon. It is, how do I say this without being disrespectful? It is exactly what we were trained to do, but it's almost like we're saying, yeah, like all of us, PT, OT, speech, nursing, psych, psychology, social service, doctor, physiatrist, all these people, it's a village, right? It's a village to raise a kid. Well, it's a county to care for a medically compromised individual. And it's, ensuring that each of those members, the CNA, all of the professionals that are involved, all of the direct care providers, and that your model promotes and endorses this. So those are the key elements there. And that but the element that I want you to know is that you, as a team member, might find that another team member may be the better point, maybe you were, that you're going to modify that. And I think that this would have comes down for dementia training. So there are some questions and answers. Again, I will add this to another training. I want to just make sure that I give time for the question and answers. And when we go back to integrative health, collaboration, client-centered. So client person-centered care is a component of 6 elements of integrative health. So and if you've heard the triple aim from CMS, it's increase your improvement of care. You're going to have better outcomes, but it's going to be less costly. And you sit there and say, well, how? Well, it's because of efficiencies. And if you have technology and you have the ability, only way you can do that, in my opinion, is technology, and that you have this verbalized, agreement and respect amongst all of the professionals that are in the multidisciplinary team. So I think that I'm going to, and by the way, health equity is another huge focus of the government, and it's about everyone receiving the same amount of care. And what you would notice in the long-term care industry specifically is Medicare Advantage, high focus on the inequality that can occur because someone that has traditional Medicare Part A and then they switch to a Medicare Advantage, the OIG has found that there's been a 18 to 20% erroneous denial of benefits that is affecting patient care. So I know that I give you a ton of information, and I'm going to pause for a second and make sure that the link, because it may not be in here. Here it is right there. There it is. This is the QR code. Let's see if this works. I got the select media team, right? So let's see how this works for you too. People are texting me, and that, like the girls, let's see, I'm going to see if this works. I don't know if it works or not, by the way. I'm going to see if it does. I think you take your phone and you put your camera on it, and it's not working for me, but that could be an end user issue. So that's what a QR code is. So if it works for anyone else, let me know. You tap on it. I don't know. That's for the younger generation to figure out and let me know. So I'm going to pause. I'm going to stop the recording so that we can, I don't record the Q&As. I probably should, but I say that every time. Let me stop the recording.